do. Доброго вечора, українські радіаційні онкологи. Слава Україні! Дуже дякуємо, що приєдналися до Case Review with ASTRO Experts для України. Before I introduce our speakers, I would like to mention that yesterday Russia hit our Ukrainian cities with missiles, resulting in over 37 dead and 3 of them, unfortunately, children, 170 injured. Among the targets were Pediatric Cancer Hospital, Okhmadit in Kyiv, and we have a lot of friends there. We collaborate with them very closely. Maternity Hospital in Kyiv, kindergartens, and college. So we'd like to express our condolences. Our condolences go out to victims and their families and loved ones. We want you to know that we are with you. A very difficult beginning, but I would like to spin it to something positive. With this course, we are hoping to help out Ukrainian radiation oncology. And today we are very excited to have a second lecture. And this session is on lung cancer. We have 2 great speakers, Dr. Percy Lee from US and Dr. Taras Izo from Ukraine. Dr. Lee is a professor and system-wide vice chair for clinical research in radiation oncology at City of Hope National Medical Center, including Los Angeles County, Orange County, Atlanta, Chicago, and Phoenix. In addition, he serves as medical director of Orange County and the coastal regions in the Department of Radiation Oncology at City of Hope National Medical. Previously, he served as section chief for thoracic radiation oncology at MD Anderson Cancer Center and executive section chief for the Department of Radiation Oncology. Dr. Lee started his career at UCLA, where he rose to the ranks of professor and vice chair for education for the Department of Radiation Oncology. At UCLA, he served as the chief of thoracic radiation oncology, residency training program director, and director of the stereotactic body radiation program, a program he founded in 2008. He is internationally recognized subject matter expert and thought leader in the clinical application of SBRT. He has over 145 peer-reviewed publications in the clinical use evidence for an application of SBRT in the clinic. Dr. Lee has international reputation in the treatment of thoracic and GI malignancies. He pioneered novel radiosurgery and SBRT technologies such as MR-guided radiation therapy in the clinic with more than 55 peer-reviewed publications on this subject. He led the clinical implementation of MR-guided radiation therapy program at UCLA as the 3rd site in the world with this innovation. In addition, he is a clinical trialist who is interested in combining novel radiation therapy approaches with new drugs to achieve improved outcomes in thoracic malignancies. He served as various leadership roles within national organizations such as ASTRO, RSS, ABR, and ARS. Dr. Lee was born and grew up in Taipei, Taiwan, until the age of 9 and has family throughout Taiwan. Welcome, Dr. Lee, and thank you so much for your support for Ukraine. And our second speaker is Dr. Taras Izo. He's a radiation oncologist and assistant professor at Lviv Regional Cancer Center at Lviv Medical University since 2018. Welcome, Dr. Izo. Thank you so much for preparing a few cases with questions to be shown after Dr. Lee's presentation. Dr. Lee, the mic is yours.
Thank you so much for the kind introduction. And I was just telling Natalia last time we spoke, this is really a very worthwhile effort, and I applaud everybody who's in Ukraine, taking care of cancer patients in this really challenging times. Am I still sharing my screen? Because it looks...
No,
okay.
we don't see your presentation.
Oh, does that help if I...
Yes.
No? Okay.
And then
yes.
You need to put it in presenter mode.
Yeah. Okay, perfect. I don't know why it came out. So that looks okay to you?
Yeah, looks great.
Okay. All right, I'm gonna skip that. So I think the topic, and I'll try to keep on time, is to focus on radiation therapy for thoracic cancers, mainly non-small cell, small cell lung cancer. And sort of overview, I'll speak to by cases, stage 3 locally advanced disease, stage 1 oligometastatic, and then limited stage small cell lung cancer. we all know that lung cancer is pretty prevalent in the world. About 80% of all lung cancers are non-small cell, but I think that's just the tip of the iceberg. We know now that within that, you know, majority is adenocarcinoma and then squamous cell carcinoma, but we also know more that, particularly in adenocarcinoma, that every day or every week, every month, that we're learning about mutational status as being relevant because of more novel therapy targeted to these subsets of lung cancer, such as EGFR mutation, ALK, et cetera. So I think we need to, radiation oncologists need to understand that because the drug landscape is changing. And so that's going to affect when and how we do radiotherapy for lung cancer. Just briefly, this is sort of the algorithm one would go through to obtain the diagnosis. So oftentimes one gets diagnosed because they have symptoms or X-ray or CT scan shows a lung mass. And oftentimes, if possible, we would then go ahead and get tissue through various approaches, CT guided, endobronchial guided bronchial lavage, less likely, or at some point, at some situations, surgical biopsy may be the only way to get tissue. The central to staging is a PET-CT. I know that access to PET-CT may be limited in Ukraine and other countries, and we can talk about what the implications for that is for treatment and staging, which is a lot because we don't. If we don't get a PET-CT, we often will miss metastatic disease and treat it somewhat over treatment of or sequencing the treatment with local therapy when really they need systemic therapy first. Some of the things that we typically do are evaluating for surgery, such as pulmonary function tests. Smoke cessation is something that we should be doing more often. I'll be the first to admit that it's not something that we always have time to counsel patients on, but it's important to remember that that's something that will affect their quality of life beyond the cure or not cure of lung cancer. So moving on to locally advanced cancer, I'll start with this case. This is a 69-year-old man, someone who was treated at actually MD Anderson with 40-pack year of history, smoking, chest pain, fatigue, and weight loss. And initial scan showed what appears to be a 2 cm lesion, but that's just the tip of the iceberg. A PET-CT was then obtained and it showed bilateral hilar disease, mediastinal adenopathy throughout, supraclavicular disease, particularly on the right side. And then this is just to illustrate sort of the stations of the mediastinum that one can obtain tissue from and via what methods. So endobronchial ultrasound is kind of the mainstay, I would say, in 2024. And that typically can sample bilateral paratracheal level 2s and 4s, subcarinal level 7, hilar level 10. Occasionally, you might need to get an EUS to biopsy through the esophagus for perisophageal lesion 7, 8, 9. But typically, you just sample the lesion that has the highest chance of getting a diagnosis that allows you to stage it most appropriately. So if it's a metastasis, for example, in the liver, you would biopsy that because that would determine the ultimate stage, stage 4. So in this case, in addition to the PET scan, MRI was obtained that was negative for metastases, and tissue was obtained through the supraclavicular lesion, and that showed adenocarcinoma. And by stage, this is a T1N3M0 disease based on what I discussed, a tumor around 2 cm and adenopathy in the bilateral mediastinum and supraclavicular region that makes it, based on this current AJCC system, stage 3B. This is being updated. I think we'll have a new version in the next 1 to 2 years, and it will be modified slightly. So for stage 3B, what are the management options? And taking a step back, this is the question. So Talia, should I read this or should I just go
Yeah,
through?
go ahead, read it.
Okay.
I'll launch the
Okay.
poll.
Perfect. So what is your treatment recommendation for clinically stage 3B at lung adenocarcinoma involving the right upper lung? The options, chemoradiation to different doses with adjuvant immunotherapy, or is it, chemo followed by surgery, or chemo plus immunotherapy followed by surgery? Oh, it's really cool to see live answers here.
Yeah. So you see on top the percentage of participants answered. So we'll wait till approximately 90-95% answered.
Okay,
Mhm.
perfect. It's like answer A is winning. It's like a race, like a horse race.
Mhm. And just a reminder for everyone, нагадування, що якщо ви будете відповідати, так ми будемо зараховувати вашу відвідуваність. Відповідайте, будь ласка. A few more answers, please. Okay, if nobody is answering, I'm ending the poll and now sharing the results. Would you like to comment?
Yeah, so it's interesting. Looks like both A and B are popular answers. Radiation, chemo radiation to 70 gray versus 60 gray, followed by immunotherapy, durvalumab. I would say I think the best answer would be probably B, chemo radiation 60 gray, followed by immunotherapy. Again, understand the challenges of potentially not being able to give immunotherapy in different parts of the country, not just Ukraine. I think there's other countries that have this challenge. But I would say answer A is probably not the right answer because I'll share some data that dose escalation beyond 60 gray, at least as far as we know, based on standard fractionation, has not been beneficial. There's a study that showed RTOG 0617 that directly looked at this question. The other questions about answers about chemo followed by immuno, that's possible. I think with all these drugs, therapies that are in the market, there are some thought, can we extend surgical options to some patients by downstaging with chemo and immunotherapy? I would say right now we're not there yet, but I think people are exploring that option at some point. Upfront surgery is probably not a great idea. I don't think you can resect all the disease, especially supraclavicular and all the mediastinal disease. So you're likely going to be left with a big surgery, a lot of recovery complications, and then you still probably have to radiate because they're going to recur very soon after that, even with systemic therapy. So let's see, do I go back to my screen? Or...
You can just close that
Oh, okay.
window.
Oh, cool. Okay, cool. Let's go. All right. Wait, and then somehow are you still seeing my
Yeah, we can
oh,
still see your slide.
slides? Oh, okay. I just have to click it. Okay, got it. So this is sort of a kind of a general paradigm in looking at the red box. So stage 3 lung cancer. I think first we decide if it's surgical candidate and who's surgical candidate. I think that's evolving. If they're resectable, if they're medically fit, if they have single station, for example, mediastinal disease, then you can offer them neoadjuvant therapy followed by surgery with or without radiation afterwards. Or, if they're not operable or there's no access to a thoracic surgeon or a surgeon, then chemoradiation is the standard of care, I would say. So as far as timing of the chemo and radiation, this is an older study, RTOG 9410, that defined the standard of care, I would say, for sequential chemo followed by radiation versus concurrent. And these drugs are different than what we use today, but the concept still applies with platinum-based chemotherapy. With concurrent chemo radiation, when possible, there's approximately 2 to 3 months benefit in median overall survival and 5-year survival. So that's what we would prefer. But some patients you may have to start with chemo for reasons we can discuss: bulky disease, patients not fit, no access to radiotherapy. So it's not wrong to give sequential therapy. It's just prefer to give concurrent chemo and radiation. So how do we simulate these patients? Oftentimes, well, just talk about that. So often we would simulate with some sort of immobilization device. Here we use a backlock or alpha cradle. Um, Ideally, they can have their arms up. That gives you more degrees of freedom for the planners to create the most conformal plan, especially if you have to treat oftentimes bilateral mediastinum. Motion management is, I think, critical in all lung cancer. And again, I understand that maybe this is not accessible in certain parts of the country or in general, but typically we would do what's called a 4-dimensional CT scan that builds upon basically a movie of the lung at different phases, with 0% being deep inspiratory to close to expiratory phase at the 50% in the whole cycle. So you do this, and you can see that this particular cancer is quite mobile, and you can see where it is at different phases of the scan. With this type of scanning, whether it's kind of bend or phase-based, you can create various tools to help identify what's called an ITV or IGTV, or basically the full extent of the motion of the tumor in their whole full respiratory cycles. And whether you contour them at each of the phases or use what's called a MIP, projections of all the phases to contour your IGTV, there's pros and cons of each. For example, if it's near the diaphragm, the MIP may not be the most helpful because the soft tissue of the diaphragm would obscure your tumor edges. So you may need to contour on at least some of the phases to generate this ITV. If you don't have a 40 CT, historically what people have done is do a scan of expiratory breath hold and inspiratory breath hold and a free breathing scan, and then that's a reasonable surrogate for extent of motion. But I would caution to say that when people do hold their breath, they may overdo it, underdo it, so it's not the most reliable way to determine tumor motion. So the question two is, based on what I just shared, what is your treatment volume for this case, stage 3B? Do you treat gross disease plus 1 centimeter, or gross disease plus 5 millimeter, gross disease plus motion, as I mentioned, IGTV plus 1 cm, or that IGTV plus elective nodal volume in the mediastinum plus 5 millimeter to 8 millimeter CTV plus 3 millimeter PTV, or do you use IGTV plus CTV plus a PTV?
Few more answers, please. Great, almost 90% answered. I'm ending the poll, sharing the results.
Great. So it looks like the answer that was most popular was D, which is gross disease plus elective nodes plus PTV margin, the CTV margin. I would say, I think, and I'll show some data on this, typically we would prefer answer E, basically not treating elective nodes. We used to treat elective nodes probably 10, 15 years ago. We've learned that that's an additional volume of radiation with, I would say, little benefit. Tumors don't typically, patients don't really typically recur in the left nodes. They can, but the percentage is relatively low. But I think the concept that is correct. We want to consider a IGTV motion. We want to consider a CTV because there's microscopic spread, and we want to consider a PTV for setup considerations. And then there's nuance there depending on what you can get away with based on the plan and what you're trying to spare: lung, esophagus, heart, etc. So should I close this? Oh, there we go. So yeah, as I said, we would do a motion assessment by a 40 CT, build an IGTV, add between 5 and 8 millimeter for CTV expansion, crop that out from tissues that we think it won't expand into the cancer, for example, bone, vertebral bodies, maybe airways in some situation, blood vessels, large vessels, esophagus, aorta, pulmonary artery, and then consider a PTV based on how accurately you think you can set up the patients on the machine. And no elective nodal radiation. We only treat what's visible on PET or what's been biopsy showing disease on EBUS. And why don't we do elective nodal radiation? Well, there's two, I think, studies, and there are others that show elective nodal radiation is not helpful. And if nodal failures over time is less than 10%, especially with modern, I think, chemotherapy and now immunotherapy, there's less toxicity, by treating less regions, less lymphopenia, less cardiac doses, less lung doses, so patients would tolerate better. So that's become the standard of care, is to avoid elective nodal radiation. Now, sometimes if you see a PET positive knee lesion, but the biopsy is negative, you may decide to treat that nodal station because you don't believe in the biopsy. And that's totally fine. We do this all the time. We have to make a decision based on our clinical judgments.
Percy, what about if you
Yeah.
don't have a pet available?
Yeah. Right. That's a good question. I mean, I would say you use a contrast CT and then work with your radiologist and say, what do you think of these lymph nodes? What's the proportion of them being positive based on size and the features? EBUS, if biopsy, I mean, ideally, if that's accessible, you have a good doctor that can access the lymph nodes, you can use that information to decide which nodes to treat. But then, it's basically based on the CT, I think, and then the EBUS findings if you don't have a PET.
Okay, thank you.
Sure. So what though? So we talked about that in the first question. So this is a landmark study, RTOG 0617, that compared high dose radiation, sort of 74 gray versus low standard dose 60 gray, with or without cetuximab. The cetuximab, I won't touch too much about it because it was negative from that standpoint, but patients got concurrent chemo. This was not done in the era of immunotherapy. This was the preconceived notion was that higher the dose, the better, based on some earlier phase 2 studies. And so this was a large planned study of over 500 patients, but this closed early at about 417 patients in an interim study that showed futility of the higher dose in terms of toxicity and overall survival. And they ended the study early because patients were not going to be beneficial. It wasn't going to be a positive study for the higher dose. They did not want to hurt more patients by giving half the patients the 74 gray. And this is the survival curve between 60 gray and 74 gray. Notice that the 60 gray had significantly better survival, and the curve split pretty early on at 6 months, 9 months, and a year, clearly a year, and it maintained difference of 9 months by median overall survival. What's interesting was also the fact that local failure rates were actually higher in the higher dose, which hard to imagine. I think there are a number of hypotheses. None of them have been completely validated. And for example, is it because people were trying to treat to a higher dose, they were cheating off the margins and having marginal misses? We don't know. Maybe they were worse actors by just default, maybe using technology that's imbalanced. Who knows? But this is counterintuitive to have higher local failure with higher doses of radiation. So going back to the case, I certainly understand that proton therapy is not available in most centers, even in the US, but this was a case where a proton therapy was used to achieve 60 gray to the 30 fractions. Occasionally we'll do what's called, SIB, right, to boost the tumors, and that's still done in 30 fractions. And I think that's reasonable approach if you want to escalate the dose, because generally it doesn't compromise your OAR or lung DVHs by doing that. That's an MD Anderson approach, but a 60 gray and 30 fractions is a completely reasonable approach without SIB. And the chemotherapy, often either weekly carbotaxol or every 3 weeks cisplatin and Alimta, pemetrexed. It just depends on your oncologist and what's available, what's easier. Carbotaxol is easier to tolerate, but maybe has a little higher risk of pneumonitis. But this is kind of a common regimen, most common regimen, I would say, with chemotherapy in the US. These dose constraints are easily accessible on the internet through NCCN, and we typically try to keep the mean lung dose less than 20 gray, V20 less than 35%. There's controversy about V5. Most recently, there was an article published as a secondary analysis of the trial I presented that shows V5 may not be that important, but the V20 is. Similarly, it shows that besides trying to keep the mean high dose as low as possible is great. So it's important, like between 20 gray and 60 gray volume, you want to keep that low. What's the easy way to remember this is, for example, the article says V40 gray less than 20% when it's possible, or V50 less than 25%, and V25 gray less than 50%. Those are some of the numbers we look for. And so that's something you can work towards with IMRT to optimize cardiac dose. Similarly with esophagus, again, I think we're aware the mean dose being 34 gray, but one metric is looking at V60 gray less than around 17 to 20%, trying to achieve that would significantly minimize the risk of, I think, grade 3 and higher esophagitis. As far as toxicity, one of the things we worry most about is radiation pneumonitis. And I know you all know this, but this is a summary of what happens when this happens. So typically, symptoms can develop 1 to 6 months after radiation therapy. Median time is probably 3 to 4 months. Presents as a dry or productive cough, shortness of breath. Some of the risk factors are older age, poor pulmonary function status. Smoking history is kind of controversial. Some studies shows that active smokers have less risk of pneumonitis. Some show that it's higher. Um, Nevertheless, I mean, I think you can't really control that if they're an active smoker or not. But typical ways to review this is complex. It's looking at the CT scan, MRI, or sorry, X-rays, mostly CT scan to see if the areas of pneumonitis on radiographically corresponds to where you radiated at 20, 30 gray volume. It's even more complicated now with immunotherapy because that can cause pneumonitis, but oftentimes you try to distinguish that by where's the changes. If it's in completely uninvolved lung that never got radiation, then more likely to be related to immunotherapy, but the treatment are all the same. So it's not like there's going to be a difference in how you treat this. It's steroids, and steroids taper for, longer period if it's radiation related, but maybe shorter period if it's drug related. Sorry, this is very small, but this is just to show how the data was acquired based on a couple of studies. This is one particular study that showed about 20% developed symptomatic pneumonitis at median time of 41 days. Most of them were grade 2 meaning symptomatic, requiring some therapy, oxygen, for example, or steroids. All the dosimetric varies matter. Again, no smoking actually increases the risk of pneumonitis in this study. And how we came up with the V20 is based on this and other study looking at here, like the mean dose of 20 gray. It shows about 15 to 20% symptomatic pneumonitis. That's something we want to keep under. Again, these are additional plots from older studies and even recent studies with Quantech that shows pretty much V20 of 35% to 37% corresponds to 10% or less grade 2 pneumonitis and less than 10% grade 3 to 5 significant pneumonitis. Anything beyond that is fairly steep. So I think going beyond 37% would be highly dangerous with high rates of grade 3 to 5 radiation pneumonitis. So based on that, again, we showed this earlier, let's belabor it. We focus on the mean lung dose and V20 for the lung. We care less today about the V5 because IMRT typically, spreads dose around and allows for higher conformality of the intermediate to high dose range, which appears to be more relevant for radiation pneumonitis versus trying to keep the V5 grade low because it's a zero-sum game. You can't keep the V5 grade low sometimes when you're trying to keep the V20 grade low as well. And these are the other metrics we discussed for the heart risk. So again, with radiation pneumonitis, I think modern day chest X-ray probably is insufficient to diagnose it because you're going to see lung changes. It's hard to tell where it is. And if you're trying to differentiate drug-related or radiation-related, it may have implications on stopping immunotherapy or re-challenging them or how long the steroid duration should be. So CT scan is optimal. And of course, you want to rule out other causes of lung symptoms like infection, PE, cardiac disease, recurrence. But treatments are, if it's radiation pneumonitis or drug-related pneumonitis, it's steroids, oxygen, and hospitalization when it's significant and life-threatening. Moving on to radiation-induced heart disease, and I would say this is kind of an active area of investigation. We don't completely understand it. In the past, we didn't care as much about it because patients weren't living as long. We also thought that it didn't occur as frequently or as fast as what we think. But the reality is that actually cardiac damage from radiation for lung cancer patients, at least, is impactful. And I'll show some data for this. And it could manifest as pericardial disease, damage to the pericardium, increasing pericardial effusion. It could manifest as cardiac damage to the muscles by causing fibrosis and heart failure at some point. It could manifest as coronary artery disease, endothelial cell damage, increased risk of acute coronary events, or also arrhythmias, as not listed here, but cardiac arrhythmias is also one of the risk factors of radiation. Based on, I think, initial 0617, a number of secondary analyses, including the most recent one, showed that patients that had got higher doses to the heart did worse, less overall survival. And part of it is that the study didn't constrain the heart very much. I mean, their constraints, you look at here, is very loose. Whereas we now know that, for example, we want to keep the V 40 gray less than 20%, or mean heart dose in 20 gray, to impact the secondary effects of cardiac long-term complications and death. IMRT is able to reduce the cardiac dose and lung doses. And even though on this study, there were more patients with larger tumor with IMRT, it was able to show lower doses to the heart and the lung. These are additional studies that came out of other places that looked at, for example, V30 gray for the pericardium, showing a big difference in cardiac events when it was above or below 46%. At 18 months. Again, mean heart dose. This is where the 26 gray came from, really. The mean heart dose of 26 gray was also very significantly correlated with coronary events. So based on this, I would say we want to, again, keep the mean heart dose, ideally less than or equal to 20 gray, but certainly less than 26. And there, again, there's a number of metrics for the heart. The easiest one to remember is V40 gray less than 20%. That's based on the most recent JAMA Oncology paper by Stephen Chung et al. And the mean heart dose around 20, and V20 of the lung 35% to 37%, and mean lung dose less than 20 gray. This is too busy to really look at, but this just shows that in the first plan, we're kind of approaching that V20 gray. I think that's that blue line, if I can see that, but it's approaching 40%. So really, even with IMPT, you can't really achieve perfect plan sometimes when you're radiating bilateral mediastinum. So the things that one can do, I guess here's a question. What if you can't meet your dose constraint and it may be too dangerous to treat? What are some of the treatment options or treatment strategies to make this a safe approach for still curative intent chemoradiation? So induction chemo, shrinking margin, but use daily imaging, shrinking margin using daily X-ray based imaging, KV imaging, adaptive replanning, meaning, after 3 weeks, if there's shrinkage, replan the treatment. Proton therapy, I know that's challenging. I don't even have access anymore to proton therapy. I have to refer them out. So,
And this is the note that
oh yeah,
this is a
reverse.
negative question, right? So is not a routine strategy.
Right, that's right. Thanks for pointing that out.
Yeah.
And people change their answers once they click.
I don't think so. I think once they submit it.
Okay.
Okay, I'm ending the poll, sharing results.
Yeah, so I think the answer I had in mind that's not a strategy would be shrinking the margin, but then use daily X-ray based imaging, because I think that's not very accurate. Modern day, we should use volumetric imaging if we're going to try to shrink the margin. That means usually daily, cone beam CT, ideally if it's accessible. The other strategies are all reasonable. You could consider, sequential chemoradiation, induction chemo to shrink the tumor. That may work in some situations. Although if it's, a lot of lymph nodes, you're not going to not treat those lymph nodes, right? It might help with a big tumor, small lymph node, and something very chemosensitive. That might help. And certainly replanning is a good strategy. If you see that halfway through or less than halfway through, there's a lot of change, shrinkage, you might want to plan to replan the patient, and then continue the therapy, resim, replan, and then restart the new plan when that's ready. That might take up to a week. So you have to be kind of be proactive in thinking about that approach. Certainly, a most practical approach is shrinking the margin, instead of, for example, 7 millimeter CTV, you can probably get away with less, and PTV, and just make sure you have good daily setup. You check the images every day and work with your therapist to make sure that things are aligned. If something, if there's something that you are focused on, you want to align to, you tell them what's important to you. So I think those are, let's see. Okay, so yeah, so induction chemo, breath hold is a possibility. We don't really talk about that using if, although you would have to be, you'd have to have a strategy to ensure to some extent that the patient's holding their breath reliably, and that's challenging, I think. Daily imaging is something you could do with modern LINACs, with cone beam CT, and should do that, adapt the replanning halfway through. Um, alternative therapies in the future that has more compact dose of radiation. So in this case, I wasn't the treating physician. This is another patient, another doctor's case. He ended up using adaptive replanning, even with proton therapy. That's not really relevant, but the fact that the tumor shrunk, he planned it again, was able to get the cumulative V20 down to less than 35% because the tumor has shrunk away. And so I think that's, probably 20% of the time, this is a possibility to resim and replan. Despite that, though, a patient had persistent cough 2 months after treatment. It eventually got worse, caused quality of life issues, shortness of breath. So what's going on? Um, it's pretty clear that it could be radiation pneumonitis based on the plan. It could be drug related because the patient got immunotherapy. It could be infection. And we talked about how to rule those things out. And eventually, the patient got some taper of steroids and mitigated that. But going back to what therapy should come after chemoradiation in general, in like 7 years ago, it would be nothing, but the patient would likely recur within 6 months to a year, have local, regional, metastatic disease, until a landmark study came out in 2018 in New England Journal of Medicine using durvalumab, which is an anti-PD-1 therapy for 1 year after chemoradiation. This study had over 700 patients, randomized 2-to-1 after chemoradiation. They didn't randomize before, but after, to durvalumab versus placebo for up to 1 year. Patients had this every 2 weeks and started between 1 and 42 days after chemoradiation. And these were the survival curve updated recently, I think in 2023, showing a significant benefit in median survival, 48 months versus 29, with durvalumab versus placebo. And this was sustained for up to 5 months. And here's at the landmark time point of 60 months, showing it's 43% versus 33% placebo. So this has become the standard of care in the US, I would say, in the last 5 years. And adoption has been pretty slow in the beginning, but consistent right now. Everybody is considered for that. Based on this study, there was no really increase in toxicity that we could tell. Grade 3 to 4 general toxicity was slightly higher, but not statistically significant. The discontinuation rate was 15%, but not that much more than placebo, in fact. I mean, people discontinue therapy just because they are sick patients. And the most common side effects is pneumonitis, not surprising, from either radiation or the drug. Death rates between the two arms were similar, actually less numerically in the durvalumab arm. So with that, switching gear to patients with stage 3, but what if they have, targetable mutation? So in the original Pacific study I showed, they included pretty much everybody, but over time, people realized that patients with, EGFR or ALK mutations, they didn't really benefit as much from adjuvant immunotherapy in stage 4 settings, even in the ad hoc secondary analyses from Pacific. So this actually came out at ASCO, and many people are already doing this, is that even though there was no good data, we all believe that durvalumab isn't the right answer. So in patients with EGFR mutations, this study randomized patients to either a Tagrisso, which is a osimertinib, an EGFR second-generation EGFR inhibitor, versus placebo indefinitely, and the endpoint was progression-free survival. And so here's the randomization after chemoradiation, either sequential or concurrent. I think it was one randomization of osimertinib versus placebo indefinitely until progression. Patient could cross over if they progress on placebo arm, and they can now get osimertinib and be open labeled, and then they follow them till death or progression. And again, this was presented at this past ASCO, and published concurrently the New England Journal of Medicine, showing a dramatic improvement in median progression-free survival, 40 months versus 6 months. So I think there's no question that there's benefit. I think we'll follow the study to look at overall survival, see if that translates to survival benefit. It's likely, I think it will, but I think based on this will be has been the standard of care, will be the standard of care going forward, in countries where it's accessible.
It was amazing to see the standing ovation for this, right?
Yeah. Yeah. I think that, and yeah, and also the small cell study, right? I guess it's because it's so impactful, and it's something that we hope for these patients, because there are a lot of non-smoking patients that get lung cancer, and now there's a clear method to treat them that's beneficial. So moving on to early stage lung cancer, let's talk about this case. So this is actually my case. This is from UCLA days. So it's a while back, I would say 70 years ago, maybe longer. 71-year-old man with cough, tobacco use. CT scan shows a 3-centimeter mass. PET avid. Biopsy showed adenocarcinoma. The patient refused surgery, and I think that's not surprising, nor is it unreasonable. He's 71. It would have been a tough surgery to begin with, but it's clinically stage 1A3, based on AJCC 8th edition. And I gave him a dose of 50 gray in 4 fractions. And so the question is, for this topic, which of these is not an essential requirement for lung SBRT? So A, use of a CTV to account for microscopic disease, use of daily cone beam CT for setup, use of multiple beams to increase conformality, use high dose per fraction, given in fewer fractions, use motion management and small PTV to minimize dose spillage. So this is, again, a negative question. Which of them is not essential or not considered, I would say, when we use SBRT?
Percy, when did you start using SBRT in the clinic?
Actually, it's at Stanford when I was
At
a resident.
Stanford? Oh, cool.
Because Stanford was early adopters, right, in
Right.
2004, 2008.
Okay.
And then so part of that is when I came to UCLA, they didn't really have a program. And the chair said, well, why don't you start one?
Oh,
And my
okay.
question in my mind was, well, I'm probably too junior to start a program. He goes, it's never too early to start one if there's no program.
That's awesome.
You know,
Yeah, that's really
so
cool.
yeah, so for better or worse, then I may miss, we learned a lot about SPOT, right, over the years and decades.
Right.
And I've certainly learned from just trial and error to some extent. And then as the field moved forward, we've just done better and better, and it broadened indications, right? With Bill being one of the people that kind of
Right. Yeah.
led the charge.
Yeah, that's really cool that there's common history.
Yeah. Yeah. So I think people
Yeah.
make
93 people
comment.
participate.
Yeah.
Yeah. Hmm.
Yeah, so I think that's correct. Majority picked the use of a CTV, and I want to just say that it's not because we don't believe there's microscopic disease. It's just we think that, and we know that by giving such high ablative doses, even with the gradient of radiation, that gradient, if it's 50% dose, is likely going to sterilize microscopic disease. So you don't need to add another CTV to it. You just have to account for motion and add a PTV. The other things are all important to make sure that you do the best you can to deliver the radiation as conformally as possible with high ablative radiation. So again, we just talked about this. I mean, at least in the US, it's artificial that we limit SBRT by 5 fractions. In Europe, it's 8. Really, the important point is that it's not that. It's few fractions. Ablative doses between, let's say, 7, 8 gray to up to even 24, 34 gray in single fraction. Margins are millimeters. Often, PTV expansions are 3 to 5 millimeters. We use as much multimodality imaging to make sure we draw the target as well as we can. And then we also have to make sure we deliver the treatment, right? Bill Liu taught me this. It's not just how you plan it, it's what are you doing to make sure that those lands where you want it to land? That means immobilization, means image guidance as much as possible in your clinic based on the technology you have, and making sure that the plan is as conformal in the high and intermediate dose range here with SBRT as possible. So, well, how do we do that? It's the things that we talked about, 4D planning when possible. You typically treat small tumors. Some are easier than others. This is an easy peripheral lesions, not allowed high real estate around. High real estate meaning critical organs like the trachea, bronchus, airways, vessels, cord. It's not in your chest wall, but some of them are, so we got to manage that. Many beams. Now we have VMAT and ARC, so by definition, there's many beams. But in the past, with static IMRT, so that allows you to have, like for example, non-coplanar beams. I just planned on recently reirradiation that I try to use non-coplanar VMAT to stay off as much as possible areas of retreatment, like the pulmonary artery. It's daily imaging, cone beam, and being on the machine to make sure that you're lined up perfectly as much as possible. If there's any changes, consider replanning. If there's fusion, or at least line up to the target. And then the steep gradient allows you to drop off the dose around critical structures, here in the case chest wall, but sometimes it's aorta, esophagus, depending on where the location is. And then by default, SBRT means high dose per fraction. In the US, it's, I would say, standard of care for inoperable patients. Inoperable defined by poor pulmonary function tests here. These are just numbers roughly, FEV1 less than 50% or 1 liter, DLCO less than 50%. To me, it's not really which machine you use. It's all the above. Could be possible depending on your comfort level, your businesses, how your approach. The principle is more important than the machine, I think. Obviously, you can't use like a 35-year-old Linac or maybe a Cobalt machine because you don't have image guidance or you have poor dose gradients, but any of the modern radiation machines is possible. How did SBRT become standard? I would say just over time, but there's been a couple recent trials that prove that it's better. In this case, this actually a trial that didn't prove it was better, not well cited. It's a space trial. It's low numbers. It didn't actually show a benefit with SBRT in terms of progression-free survival versus standard radiation or overall survival. But I think many people don't put a lot of weight into this because, for example, there was imbalance in larger tumors in the SBRT arm. We know larger tumors means worse outcome. There's also more men than women in the SBRT arm here, and that's also a poor predictive factor. It's also just a small study to show difference. This study actually was, I would say, better done, more modern. This was done out of Australia. They compared SBRT. It was a phase 3 study, multiple hospitals, peripheral lesions, randomized to SBRT 2:1 versus conventional radiation. When they say conventional, they meant 33 fractions of 2 gray, or even moderate, I think 2.5 gray times 20. And SBRT has 2 regimens, 54 and 3 or 48 and 4. And their endpoint was local control and progression. And SBRT clearly did better in terms of local control here. And actually, as a secondary analysis, did better also in survival. So this was published in a big journal a few years ago, and something we cite to show that there's been survival advantage in SBRT versus conventional radiation. About tumor location. So the definition of central came about years ago when Bob Timmerman started the dose escalation studies to look at how high can you do SBRT 2 in 3 fractions. And they didn't come up with this up front. They treated everybody with this dose escalation, and they did a retrospective analysis that showed, wow, the people that had a lot of toxicity and even died were having tumors within 2 centimeters of the tracheobronchial tree. And that was defined, again, retrospectively by some arbitrary number, like 2 cm above the carina, and then to the sort of the lobar bronchi branches. So basically, wherever it becomes the left upper, left lower, left upper, left lower, or right upper, right middle, right lower lobe, 2 cm beyond those lobar bronchi, not the small bronchus, I would say, in the bronchi, it's the larger bronchi. And then if it's within the 2 cm volume, it would be considered central. So this interesting look back historically how this came about. They had, for example, 70 patients treated on the dose escalation study, and these people got between 60 and 66 gray in 3 fractions, a very high ablative dose. And there was based on that, there was 11-fold increase in grade 3 toxicity when the tumors within this volume that we discussed. Outside of it, it was much less. And oftentimes, this is an example, not from the study, but a case example of someone with basically a central, this is probably ultra central tumor. We can talk about that in the next slides, but causing issues with necrosis of the bronchus. And you also don't want to biopsy it. This patient got biopsied, and that's a no-no. I think you should observe issues like that. It's something to counsel your pulmonologist if they're going to scope patients, not to biopsy areas that look necrotic, because that's just going to cause, adding salt to injury. And this patient eventually died of hemoptysis. So again, we've learned a lot over the years about central tumors. This is a study ran by RTOG or NRG now, called NRG, of 100 patients, and then dose escalation study in 5 fractions of central tumors. And they showed that basically they were increasing, here's a slide here, they were increasing the dose from 10 gray per fraction to up to 12 gray per fraction over 5 fractions. And their pre-specified endpoint was toxicity grade 3 or higher in the first year. And then they would stop the dose escalation if they reached 20% of that without exceeding it. And they actually never reached that. They were able to complete the study. But the problem with radiation is that some of these late complications happen late. They can happen a year later. So even though the 1-year outcomes was reasonable, for example, there were 10 deaths that happened after 1 year. So were they due to toxicity or not? It's hard to know. And also 11 patients died during treatment that was not attributable to toxicity. So again, we don't know if that's because of radiation toxicity, cardiac related, who knows? But, and there were even 4 deaths that were beyond 1 year. So I think what we learned is that if we're going to give 50 gray in 5 fractions or 60 in 5, we can get really good local controls, and there's no difference in survival. We really have to be mindful of what the normal tissue dose is around it that's getting. And there's constraints that we have learned, from Bob Timmerman, et cetera. And I would ask you all to look at the high-tech papers. There was one on lung that I did for tumor control, but there was also one on normal tissue, mostly for pneumonitis, that looked at this. And there are other papers that looked at, what is safe to be delivered around central, ultracentral tumor. One strategy, this is highlighted in the what's called the gray zone in the red journal, and we published a paper around this too, is when you're treating a central tumor, ultracentral tumor, what you end up doing is you have to decide how much you're going to give the tumor, how much you're going to give the normal tissue. And what I would say in this location, often SBRT, we want to give really high doses to the middle of the tumor so that it drops out, has a better drop off and better tumor control. But when it's central, ultracentral, you want to keep it somewhat homogeneous so that the hotspot, if you're off by a little bit, is not in your critical structure like the bronchus, or the esophagus, or the pulmonary vessels, for example. And sometimes you can have a PTV, but you probably can consider underdosing the PTV if the GTV is giving a reasonable dose, instead of lowering the dose completely to something homogeneous and lower. You have to think about, again, critically, what is around that tumor, what is the tolerance to that organ, what are you willing to accept as far as risk, and what is the indication. If this is a curable case, you might be more aggressive. If it's oligometastatic and the patient may have other mets, you probably want to be less aggressive. So those are kind of the things I would think about when we treat tumors. But now we know that more and more in the last 10 years, we can treat, I think we can treat safely central tumors. Like if it's a centimeter away from the airways or touching it by a bit 2 cm, I think that's still very safe to give 5 fractions, 8 fractions. But what if it's touching the bronchus, touching the esophagus? That's what we would consider, or touching the pulmonary artery, ultracentral. Then I think that's where the risks are really high. And here's a case that I treated back at UCLA, a tumor that was abutting the carina, so ultracentral, 6.5 centimeters, so large. Got biopsy stage 2, but limited, no sites of metastases in the mediastinum or other sites in the lung. Based on the mediastinoscopy, patient refused surgery because it would require a pneumonectomy or a sleeve resection, not really even possible. And I gave a 10 fraction regimen, 6.5 gray times 10. So there's that regimen. There's 70 and 10, or there's 15 fraction regimen that one may consider, for example, 60 gray and 15. So it really depends on how comfortable you are with that treatment. I would start kind of on the more conservative side and then work your way up based on your experience to more aggressive treatment based on patient selection. Changing topic a bit about what happens after SBRT. So we know from many studies that local control with SBRT, when the BED or biological effective dose is greater than 100, right? We know that's at least 90%. But what we don't talk about a lot is patients still have failures outside of the tumor. They have, again, in 0236, a lung SBRT study that was reported showing good local control, but with long-term follow-up, many patients recur regionally, many patients recur distantly. So the 5-year disease-free interval was very low. Nobody really talks about that. Other studies have confirmed that. And, it's between 60 to, at best, 60 to 65%, I would say, if the patient lived long enough. They have competing risk of death due to other medical issues. That's why I think this number is somewhat even artificially high or low. If they live long enough, they would have more recurrences. So what can we do after that? So this was a study out of MD Anderson, and I ran a similar study, a smaller one at UCLA that we published as well, combining SBRT for stage 1 cancers treated with SBRT with 4 or 5 doses of anti-PD-1 or anti-PD-1 therapy. This was just published less than a year ago, year and a half maybe, and we enrolled. It was something that can only be really done at MD Anderson, at really big institutions, where we put on like 160 patients over 4 years between SBRT alone and SBRT plus nivolumab, and then anti-PD-1 therapy that started at the first day of SBRT and 4 more cycles after that. And it showed a significant improvement in event-free or progression-free survival, if you want to call it that, between SBRT and plus immunotherapy versus SBRT alone. And there are 4 or 5 ongoing large phase 3 studies to prove this definitively. I would say they will read out in the next 2 to 3 years, and then probably, in my optimism, be positive studies. At least a couple of them will be positive. All right, so did I mess it up? So oligometastatic disease. I know I'm running out of time, so I'll try to speak a little faster and focus on more important points. I think oligometastatic disease is familiar to all of you. It came about through some hypotheses from Hellman and Waxelbaum in the mid-90s about certain patients could benefit from local therapy, and that their metastatic disease can be treated with long disease-free interval if locally treated. And why do we treat disease locally? So some of the rationale would be to improve systemic therapy. So for example, as systemic therapy gets better, then the patients may have treatment failures locally. So you might want to treat that. The other benefit is that tumors often acquire resistance to targeted therapy, immunotherapy. So if you treat them after some effective systemic therapy, you might be able to wipe out resistant clones. So that's another rationale for local therapy, even if the patient is doing well on systemic therapy. And also from our standpoint, I think with emerging better technology, we're able to give ablative doses more safely today than ever before, and will be even more safe in the next 5 to 10 years. And then we're understanding how this interacts with immune therapy, right? So there may be some synergy. We like to think that that's the case. We haven't really proven it, but I think there are some hints that that might be the case. Here's an example of a patient, 80-year-old woman who had lung cancer, a right lung mass, cough, effusion. Patients had an EGFR mutation, nothing else, was a non-smoker, started osimertinib, Tagrisso, EGFR targeted therapy. The patient did well after 12 weeks, had stable disease, no metastatic progression. And this was on a study. The patient was put on a study to randomize to targeted therapy plus radiation versus just continue Tagrisso. And so this was radiated to 60 degree and 8 fractions because of the size, I believe, from the tumor. And the patient did well. And so the data for this is, again, emerging. In 2019, Gomez et al. And MD Anderson and another couple of institutions looked at lung cancer after chemotherapy mostly, and some TKIs after good systemic control, randomized to radiation or no radiation versus continuous systemic therapy. And there was a local control, progression-free survival benefit, and overall survival benefit. Same, a smaller study at UT Southwestern, another study called Sabre Comet from Canada looked at not just lung cancer, but prostate, lung, breast, and other cancers. It was powered to overall survival, but again, small studies showing a signal that SBRT may improve survival. I would say I didn't put the slide in a recent LU002 study that was trying to answer this question, was negative, but that study also was very heterogeneous in histology, the type of systemic therapy. And so we're still trying to understand when to offer local therapy for patients. Here's a study that's, I would say, cleaner. They looked at patients with EGFR mutations out of China called the CINDA study, 133 patients. Patients were randomized to drug alone, TKI versus TKI plus radiation. Radiation was, modest SBRT doses, and patients that got radiation plus TKI had an improvement in progression-free survival and overall survival. And so this is a good study to remember for EGFR-driven metastatic, oligometastatic lung cancer. Okay, my last case is I don't really have a case, but it's on topic of limited stage small cell lung cancer, because I knew I was going to run out of time. So here's the question: which of these is not a reasonable regimen for small cell lung cancer limited stage? 45 gray at 1.5 gray BID, 50 gray at 2 gray per fraction once a day, 60 gray at 2 gray once a day, or 66 gray at 2 gray per fraction once a day, or 70 gray at 2 gray per fraction once a day. Which one is not a reasonable option? I should make my questions more straightforward, not the negative questions.
Yeah,
I
you
would not.
like negative questions.
I would not be a good ABR.
That's
They,
right.
they
They
don't.
don't
They
allow
don't
that.
like.
Are you ABR examiner also?
I'm a oral boards examiner.
Oh, that's cool. Me
It's
too. Yeah.
yeah. I think the written one's harder, right? It's harder to
Yeah.
come up with written questions.
Hmm. You have to be very specific.
Yeah, yeah. It has to meet a lot of check boxes, right? It can't be too
Right.
hard, too easy.
Hmm. I was wondering, you mentioned inoperable, right? For
Yeah,
SBRT. What about operable patients? I know that there was a JCOG
yeah,
trial,
yeah,
right?
yeah. Well, there's a Jake. There was that, and there was also, I didn't put it in. Dr. Chang at MD Anderson, who I worked with, they had a study that looked at operable patient SBRT versus surgery. It was cut short, like many of
Hmm.
these studies, and
Hmm.
they did a pool analysis with another European study. It was in Lancet, very controversial, showing SBRT had better survival. The surgeons did not like it,
Of course, yeah.
and there's a lot of criticism about how you shouldn't pool study, and it totally valid criticisms. But at least it raised awareness that SBRT could be, maybe not as good as surgery because it's patient selection, right? Because
Mm.
you can't really compare operable and inoperable because of
True, true. Hmm.
their cause of death are likely
Performance
going to be
status,
different.
yeah. Hmm.
Yeah, but there is an ongoing study right now called at the VA run by Drew Mokanaki, Baylor.
Oh.
It's crude about last time I asked him, I think it's like a third of the way through, so that's the most promising accrual thus far, like a couple hundred patients. The problem with that is by the time it finishes, it's going to be outdated because in my
Hmm.
mind, it's going to be SBRT plus immunotherapy.
Yeah, yeah.
So, so then
Can
the
they add
question,
the arm now, or
I think
it's too
it's too late.
late? Too
Yeah,
late.
and I think because we haven't read that out, right? We have to wait
All
till the
right.
phase 3 study. So once that's read out, I think it'll make it even more interesting, but not relevant. So
Okay, ending the
okay,
poll, sharing results.
yeah, so this is a question about what's not appropriate. So I think B is, in my mind, not appropriate because the dose is too low, right?
Hmm.
If we're going to give single daily fractions, I think minimal dose of 60 to 66 gray is what's considered standard. And that grade, 70 gray and 2 gray fractions is too high. I think 45 gray BID is a very reasonable option. Reasonable in that there's great data for it. It's just not very easy to implement, right? I mean, I think especially even in the US. I'm sure it's in Ukraine, it's it's like there are a lot of patients that need care. So if you're gonna give twice a day of
BID.
radiation, it's very hard
Mhm.
for the clinic, it's very hard for the patient. So I understand why people choose it, but it's actually probably the most standard option if you have all the resources is 45 gray BID.
Okay.
So let's see. Oops. Yeah, so that's based on an older study, Teresi, we call it Teresi study, where patients were randomized to 45 gray once a day, 1.8 gray versus 45 gray, 1.5 gray BID. This showed a benefit in twice a day radiation with overall survival, but the criticism is that 45 gray once a day, as we all know, isn't the same dose as BID. It also had a lot more, besides better survival, it had more toxicity, more new esophagitis. But the fields were larger. They were treating elective nodes. They were not using IMRT that wasn't available, and it was mostly 3D radiation. So other people have looked at this question of once a day versus BID. I just pulled this. This is a Norwegian study that looked at 45 gray BID versus 42 gray once a day hypofrac, and they were similar in progression-free survival. And there's numerically higher overall survival in BID, and also similar toxicity. So I don't know if I would accept this 42 gray and 15 fractions, but I would say that 45 gray BID looks still pretty good in the study, even though it's harder to deliver. The more recent study I would say to remember is this Converse study from the UK that compared once a day radiation to higher dose, 60 to 66 gray, actually 66 gray versus 45 gray BID. And this was powered for superiority. They were hoping to show that once a day radiation was better in terms of survival. Lots of patients, randomized 1-to-1, over 500 patients. IMRT was allowed, but mostly was treated 3D, no elective nodal radiation. Most people got PCI, good follow-up time. And in the day, 2-year survival was similar, a little bit better numerically for BID. 5-year survival was better with BID. Well, interestingly, there was no difference in esophagitis. We all think that's because with IMRT and no elective nodal radiation, it really is a safe treatment. So, and the conclusion was because it was a power for superiority, you couldn't say that they were equal. All you could say is that the BID is still standard of care. But then we can all say, look, if it's very close, I think once a day radiations can't be that much worse than BID. There was also a CalGB study I'm not putting there that showed 70 gray over once a day was similar to 45 BID. Sorry, yeah, BID means twice a day. Sorry about that. Oh, I just messed that up. So this is interesting. I just pulled this up because actually it was done by a UCLA resident that we recruited. He did a nice study of survey of US practitioners and, do they offer or prefer once a day versus twice a day? And the answer is prefer once a day. Which one's more common for your patients? 3/4 says once a day. Why do you prefer once a day? Because it's more convenient for patients. It's more convenient for me. That's for the clinic and me. And then those that says, why do you prefer twice a day? It's because it's shorter treatment. Even though it's twice a day, it's technically right half the number of weeks. So, that may be possible for someone who lives very close to your center. And it's more established. That's true. And it's not once it has not been proven superior. I can tell you, MD Anderson, back at least when I was still there 3 years ago, 2 years ago, we were routinely recommend BID based on just being very regimented in the data that twice a day is still the standard of care. What does it say? Recommend. So, what dose would you recommend here? So most people, if you're going to do once a day, would give probably 60 gray. A few would give a little higher. Very few would get like less than 60 gray. Similar BID is 45. There is a study, again, the same Norwegian group did a 60 gray BID versus 45 BID showing a benefit in survival. I don't think it has kind of been adopted in the US because people don't really believe the data because they didn't show that it was more toxic, which doesn't make a lot of sense. It was also a small study. Plus, I think we'd move beyond just the radiation dose. And I'll show that here. This is again presented at ASCO, very new study that showed in small cell limited stage. They allow both, by the way, BID 45 gray versus 60 to 66 gray once a day. And it was very much like the Pacific study. Afterwards, they randomized patients to durvalumab, anti-PD-1, placebo, or a combination of a PD-1 and an anti-CTLA-4. They haven't reported this arm because it was actually cut short. But just between the two arms, um, they looked at overall survival as endpoint, and this was just reported at ASCO at 37 median time of follow-up. The use of durvalumab for 2 years, this was a 2-year study after chemoradiation, was significantly better than just chemoradiation. And if you look at the 3-month outcome, it's 56% versus 47% for survival. And then for median survival is a 20-month difference. So this is practice changing. Again, I think eventually we'll make it to more access globally. It hasn't actually been FDA approved. This just reported 3 weeks ago, but this will be the standard of care. And I pretty much know in 1 year here, but certainly in 2 to 3 years in other places. And this is a nice summary of what we've done in limited stage and extensive stage. So immunotherapy has been used after chemotherapy in other studies, large studies. Caspian was with chemo and plus minus durvalumab, and Power 133 was chemo plus minus atezolizumab. And in extensive stage, where radiation is not as involved, it was only 2 months benefit. But if you look at limited stage in small cell and then Pacific for a non-small cell, the difference is much more dramatic. It's 20 months here and 10 months or less than 10 months. So the question is, why the big difference? And I like to argue, we like to argue it's because, in limited stage, curable stage, when you intensify therapy up front, it's better than trying to catch up when you're stage 4. So you can't compare the difference, right? Because this is 23-month benefit versus 2. So I think this is a lot more impactful when we give chemoradiation. And maybe there's some synergy with chemoradiation. That's what we'd like to hope. But it's also because probably these patients are healthier, able to tolerate therapy, and more impactful combining that with radiation. So I think that was my last slide. Just in summary, I think there's a role for SBRT clearly for inoperable non-small cell, but maybe some operable as we discussed, certainly borderline patients are sicker than the typical operable patients. I think that in stage 3, there's competition between surgery and radiation for who's the best candidate for what. But eventually, consolidated durvalumab remains standard of care in patients that were treated with chemoradiation that have no EGFR or driver mutations. In those patients, we would give osimertinib or Tagrisso. And then there's a lot of exciting data on the use of consolidated radiotherapy in oligometastatic lung cancer. And then in limited stage small cell lung cancer, there's more and more data about adding immunotherapy after chemoradiation. I just showed that with significant benefits. So let's see, hopefully I didn't run too much out of time.
Thank you so much. That was really amazing lecture. I learned a lot from it, and it was very well structured. Thank you. And the questions were
Sure.
really great. Thank you so much.
Sure.
Let's have Taras share the slides. If you can
Oh,
stop
and share.
sharing. Yeah,
Yep.
unshare. Thank you
Sure.
so much. So we see some questions here. How to technically execute BID in your clinic? And do you use BID in your clinic?
Yeah, I'm trying to share. Did I share? Yeah, I'm sure. Do I use? Yeah, in Houston we did a lot of BID. And then they especially during COVID, a lot of patients have nothing else to do, right? I mean, they came to clinic and they got treated, and also if they came from far away, they drove from Louisiana, which is a neighboring state. They had luck. They actually would prefer to stay shorter, if that makes sense, because it's less expensive, right? It's 3 weeks versus 6 weeks of being a distant location. I frankly think that they're equal, and based on the data we know, I don't know if the BID is really that much better. So if it's more convenient for your clinic, I would do once a day. If it's more convenient for a patient, I would do once a day. I would just make sure the dose is sufficient, 60 gray. I think with this idea of adding immunotherapy afterwards, that's actually making a bigger difference than, as big of a difference, if not bigger than chemoradiation. How do you implement it? It's tough, right? They have to be 6 hours apart. The
Right, right.
patient, yeah, you have to treat at the end of the day.
Mm-hmm.
It's resource intensive.
Right.
I mean, how do you do it? I mean, I don't
We
think
do
there's any
it.
magic.
We do it at Stanford, but not for lung. We do it for TBI
Yeah,
or quad shots. Those are BID, but it's a challenge to schedule patients, definitely.
yeah, yeah.
Okay, let's have Taras ask his questions. He prepared two cases, I believe. Taras, go ahead.
Yes. Hello, thank you for great lecture.
Hi, how are you? Thank you.
Case first, female, 68-year-old, non-smoker, pathophysiologically adenocarcinoma grade 2, CT scan of the chest, abdomen, pelvis, plus intravenous contrast, peripheral first S2 tumor of the left lung with invasion of the paramediastinal pleura, mediastinal fat, anterior segment artery, superior lobar artery, and occlusion of the last one by tumor mass. Lymphadenopathy of the mediastinal lymph node, no evidence of distant metastasis was found. MRI of the brain plus intravenous contrast, no evidence of secondary lesion. Locally advanced non-small cell lung cancer, T4 N3 M0 stage 3C. Treatment plan, definitive radiation therapy, 60 gray in 2 gray per fraction plus concurrent paclitaxel and carboplatin UX2 weekly 6 cycle. Simulation CT scan obtained in the radiation treatment position plus intravenous contrast. CT with the 3 phase of breathing, rebreathing, inhale and exhale. Involved field irradiation. GTV is primary tumor plus clinical positive nodes, contour primary tumor using lung windows setting. CTV is GTV plus 6 millimeters. ITV is CTV inhale plus CTV exhale, and PTV is ITV plus 5 millimeters. We use daily CBCT and VMAT technology. And a question for this case, how would you treat this patient? Would diagnostic methods are essential for staging and contouring when PET-CT imaging center are not available? What is the optimal CTV margin for adenocarcinoma? And do you use different margin for squamous or small cell? What is the optimal accompanying therapy and possibility of radiation in case of local progression?
Yeah, I think I would treat the patient similarly. I mean, I think if assessing motion like you have to the best that you can and counting for that in your IGTV, that was a very similar case actually the one I presented, very extensive. PET-CT, if it's not available, we talked about using a good diagnostic quality IV contrast enhanced CT scan to outline the nodes. And I don't know the accessibility of EBUS. If that's accessible at your center, if there's a good pulmonologist, I would definitely do that because that will give you information about which stations you need to treat. There's actually a nice paper out of Australia that we participated in that looked at concordance of EBUS and the PET and showing that actually, EBUS is better. I mean, it makes sense. EBUS is tissue-based. And what is the optimal CTV margin? So that's controversial. I mean, you ask some people, and some people will say CTV margin is probably not that important, right? Because we kind of made the data for that was a little bit, I want to say made up. They looked at the pathology specimen. They looked at how much the cancer extended beyond the tumor. With a squamous cell, it's a little bit more than the adenocarcinoma. But that makes sense. But we know that radiation it's like not a sharp knife, right? If you give a 5 millimeter CT margin versus a 6 millimeter, do you think that will make a big difference? I personally don't. So what I've done is I customize it based on disease volume, right? Or like if I have a very bulky tumor, I'm willing to take a smaller CTV margin. I'll take like 3 to 5 millimeter, and then add smaller PTV margin if I'm confident that we're not going to be missing gross tumor. Now, if I have a small tumor and I realize that small tumor and then one node and I'm more concerned about missing the tumor, then I'll add a larger CTV margin because I know that it's not going to impact toxicity. So I'll add 7 millimeter. So I think I don't differentiate ano versus squam. I don't think that 1 millimeter is going to make a big difference. I try to do at least 6 to 7 millimeter if I can. But my total margin, I would say, is between CTV plus PT between 1 and 1.5 centimeter. I also think longitudinal margin is like super if it's more important than axial sometimes because of, yes, we're not supposed to use this CTV to account for motion and uncertainty, but we know that our dose is very steep sup inf, right? Like just like an SBRT, if we miss a slice or not, it's gonna underdose the top of the tumor and they may recur there. So I'm more lenient on I'm more generous on the margin sup inf than axially for PTB at least. Optimal complement therapy, I think it will be durvalumab if they're not, if they have PD-1 expression at least 1%. TKI if they have EGFR mutation. Re-irradiation, it's possible.
Sorry.
I think that's all right. I think re-irradiation is possible. I think it's high risk. I didn't really touch upon that, but there's a set of literature, very scant literature about how do you re-irradiate. And typically you want to have composite plans. Number one, you want to, if you can, you want to look at the time interval between original course and the second course. Better to be at least 6 months, even better a year. The longer the better for the patient and for toxicity. And then with normal tissues, I think the ones we would be most worried about are esophagus, large vessels, pulmonary artery, tracheobronchial tree, spinal cord, of course. And the spinal cord has its own set of constraints, but the other ones, we like to look at cumulative EQD2 around ideally 100 gray or less. Now, understanding that that's not a lot of room if you're like treating a big tumor up front and it's 60 gray, you have very little left. So you have to kind of make some decisions about that case by case.
Thank you for answer. In our center, we have IBUS. Yes, it's the second center in Ukraine which use this technology. And the second case, a male, 41-year-old smoker, 18 years, bronchoscopy protrusion of the membranous wall of the proximal lobe of the left middle bronch without mucosal change. The left inferior left lobar bronch is still light narrowed. Biopsy squamous cell carcinoma grade 3. PET-CT, a sign of tumor in the lower left lung lobe, mediastinal lymph node involvement. Neoadjuvant system therapy, paclitaxel plus carboplatin UX6, 4 cycles with the effect of tumor stabilization. Then surgery, extended pulmonectomy of the left, pathophysiologically squamous cell carcinoma grade 3 R0 and in subcranial nodes. Locally advanced node small cell lung cancer, PT2N2M0 grade 3 stage 3A. Postoperative radiation, 54 grade in 2 gray per fraction, 6 weeks post-surgery. Resected CTV bronchial stump involved lymph node area, subcranial nodes, CTV mediastinum resected, CTV plus 1 centimeter plus ipsilateral tracheal lymph node 4 node station, ITV and PTV is ITV plus 5 millimeters. Daily CBCT and VMAT technology. Question for this case, how would you treat this patient? What is the optimal time to start radiation therapy after surgery or adjuvant chemotherapy? What is the tactic if we decide a few small lymph nodes up to 10 millimeters? And a few questions of my colleagues. Should atelectase be included in the radiation field if there is no PET, and to what extent? Should the pleural tension from the tumor be included in the tumor volume? Involved field irradiation or elective nodal irradiation for small cell lung cancer? And are there any hypofraction option for non-small cell lung cancer? Thank you.
Sure. So to answer the question about the case, so that correct me, that's a case of non-small cell lung cancer surgery and then some nodes involved and negative margins, right? I think. So things have, I would say, shifted quite a bit in the US and I think other UK maybe in the last 2 years. There's been 2 studies that were disappointing. One called Lung Art study from the UK that took a long time to approve about postoperative radiation, and one's called Port C from China. But bottom line is both studies showed that adjuvant radiation after surgery did not improve disease-free survival or overall survival. This is very disappointing that we obviously want to think that radiation is helpful. But in those studies, they were not. It doesn't mean, but I guess what I'm trying to say is that we've kind of shifted away from giving adjuvant radiation routinely for a nodal disease, N2 disease. We were routinely doing that 2.5 years ago, 3 years ago, and based on other studies that showed maybe there was a survival benefit, for example. But do we still do it? We discuss it. I think it becomes more nuanced, and so some of the things that you can consider, obviously discussion with your colleague. Also, you can look at after surgery. If there's a positive margin, I think you should radiate, right? If there's a positive margin, that makes sense to radiate. Mm-hmm. If there's no positive margin and there's lots of the patient had chemotherapy for surgery and they still have lots of nodes involved, you can argue to radiate or not radiate. You can argue radiate because the patient didn't respond to chemo. And so maybe radiation would help sterilize microscopic disease because the chemo is not working. You can also argue the opposite, that if they didn't respond to chemo, what if they have higher potential for metastatic disease? What's the radiation going to do for that patient? Right? We don't know. The other argument is also often in the US, they get chemotherapy and immunotherapy. If they don't respond to either, then the argument could be that, yeah, the radiation, you might want to do it because, look, those are the good adjuvant systemic therapies. And then the only thing left to do is radiation therapy. So, I think it's kind of maybe synonymous to what we do in pancreatic cancer. We don't, adjuvant radiation hasn't been proven to be that helpful, but recent ASCO said if you had only no nodes involved, that it was helpful because they would recur locally. So I think in today, we would just discuss it case by case with the tumor board, the patient, the surgeon, and decide whether radiating would be helpful. If you're going to radiate, I would definitely advocate for IMRT because, one of the criticism for those studies is because they died of other things, right? They did 3D and they treated larger fields, treated one station above and below. The cardiac doses were higher. The non-cancer related deaths morbidity was higher. Typically, we don't see that, at least at centers that use IMRT or proton therapy. So maybe it's about technology, but it's kind of hard to argue that because we can't keep using that argument over and over again, right? If we keep seeing negative studies, we can't say, well, our new technology today is better than yesterday. That's always true, but the studies, why we do the study is to show it's better or not. So some of the other questions about, so again, sometimes we radiated just that nodal. If they had one station that's positive, we radiated that, it's not that morbid. Maybe it gives you local control. The way to look at it is if you don't do radiation, you can wait till if they relapse locally, you radiate them then, right? They definitely need treatment then. They have a regional recurrence, they're still salvageable. If they recur metastatically, then radiation wasn't going to solve the answer. Some of these other questions about atelectasis, I would not include them in radiation field if they're not PET avid. I think that's one benefit of having PET is to rule out, you reduce your volume of disease if you don't think that's cancer. Whether you include the extensions from the tumor, I do. I mean, that's a subjective, and that's what Bill Liu used to do, so that's what I do. REST-PRT, I think it's just like if there's little, pleural extensions from lung SBRT, it may be cancer. It's not adding more morbidity. So I typically do include that. I know some people don't. I do. Involved field, you'd like to know though, involved field, I think that's sort of been the standard for the last 7-8 years, without just kind of following the suit of non-small cell lung cancer and knowing that they recur more in other areas outside of the lung. Generally, margins, we talked about that, 5 to 7 millimeter, smaller if you are going to be running into trouble with meeting those constraints for cell toxicity purposes, in which case is 4 or 5. So this is a good question. So sometimes if you have a bulky small cell lung cancer, it's, 45 gray is lower dose than 70, right? It's easier to meet those constraints when you do 45 gray. So that's what I would do. So like that's one reason to do BID is if you are having a lot of trouble meeting your V20 or hard dose, you can do 45 gray BID and you should be able to meet the dose constraint there. Although the core doses should be lower, right? 36 to 38 gray.
Right.
But the V20, it's easier to meet that. Car dose meter, easier to meet that. Hypofracture approach, yes. I think I did a study. Actually, I didn't put it in. That we were very aggressive. We went up to 75 gray and 15 fractions with chemo with really good local control, regional control before durvalumab. It's a little crazy because it requires adaptive replanning, PET, small margins, and all that stuff. I wouldn't advocate for that. But if someone can't get chemotherapy who's older and frail, one could consider a hypofractionated approach, 60 gray and 15, 45 gray and 15.
We do that here at Stanford.
Yeah, 52.5 and 15. That's a kind of, we have this regimen of 45 and 15, SIB to 50.5, 25 or 52.5. If that's, too close to the airways. If it's not, we do 16, 15. That being said, this was compared, a recent study where hypofracture wasn't better than, chemoradiation. I think it was a UT Southwestern study. So, but that doesn't mean that it's not a good choice when someone can't get chemo, right? They can't get chemo. You might as well be a little more aggressive with the radiation. So.
Thank you so much, Dr. Lee. I know you're a bit busy. You have another meeting.
Yeah.
Do you need to leave now, or we
yeah,
can ask one question?
I can stay for, let's say
one question. So there's one question from Ludmila. My patient has upper lobe left lung cancer T2 and 0M0 after 6 courses of chemotherapy, histology, neuroendocrine small cell lung cancer, received EBRT, prophylactic radiation of the brain as the first part of treatment, second part, course of EBRT on tumor, received 26 gray, everyday dose is 2 gray, and today he reported that he had chicken pox. What is your opinion? Should I continue course of EBRT after such a big break after chicken pox? And what treatment do you recommend in this case?
So if I understand the case, so the patient had chemo radiation and then recurred, and then this is a second course of radiation. And during this course, probably shingles, or is it chicken pox? I mean, more likely
maybe shingle, you think? Okay.
Probably shingle, unless it's very rare, I think, today to get chicken pox this late in life. But shingles is common. Reactivation of shingles is common actually during radiation. I've had many, many patients whose shingles or zoster came back. I mean, I guess the difference would be you'd be in one dermatome. If it's just shingles, I would just give him medicine for shingles, the antiviral medicines, and continue treating. Because I think if you think the treatment is beneficial, radiation, you should treat. Now, I guess the question is the treatment break. I don't know how long the break was. Is it 2 weeks, 3 weeks? I mean, if it's too long, if it's been too long, then maybe not be helpful. But if it's like only a week break, and I guess I would.
So she says today that the patient reported, and she doesn't know what to do to continue treating or not. How long of a break? How long of a break would you give?
Again, it depends if it's really chicken pox or shingles. If it's just shingles, I think I wouldn't give any break. I mean, I've treated through that and just gave antivirals. I mean, you have to be considerate of the fact, where is the lesions on the skin? Is it close to your radiation field? If it's not, if the tumor isn't, budding chest wall, I don't think there's a risk. You just have to make sure you get antiviral Valtrex. I don't know what the generic name, but it's usually like a 20 day course. I actually just, not recently, but within the last 6 months, did that for a patient who actually had lung cancer, had shingles. We diagnosed it, we gave antiviral, we just kept treating. Yeah.
Okay, thank you. And the last question, febrile neutropenia, how frequently do you observe it? Or small cell?
Yeah. It's, I think it happens. How often our medical oncologists deal with it mostly. I think they have to make sure that they are not, they're not infected or anything like that. Again, I have a high threshold for not treating with radiation. I think they can hold the chemotherapy because that's what's causing more of the neutropenia. It's not the radiation. We can cause, issues with the T cells, but neutropenia is chemo related. They can hold the chemo. If they're well enough to be not in the hospital, I would continue treatment. I mean, a day or two break to kind of diagnose it, but I'm kind of on the side of you don't want to, why you shouldn't be giving someone too long of a break when it's safe, because radiation is curative, and the longer the break, the worse, the less likely they're going to be cured. But they can, just hold the chemo and monitor them.
Okay, thank you so much. I know you're
Sure.
busy. You have to leave for another meeting. Thank you from the
Thank
bottom
you.
of our hearts. It was excellent lecture. We all enjoyed it. Thank you.
Thank you. I
Thank you
appreciate
so
it.
much. Thank you for your
Bye.
support. Bye-bye. Bye,
Sure. Bye.
everybody.